Good afternoon, ladies and gentlemen. First of all, I would like to thank KDIGO-KSN for inviting me to give this talk in the KDIGO-KSN Joint Symposium in this year KSN virtual event. And I'm going to present my talk on the KDIGO Controversies Conference about blood pressure and volume management in hemodialysis patients. And this is a conference held in 2019 February in Lisbon. So I'm going to cover the following aspects, including blood pressure measurements and targets in hemodialysis, volume-related patient symptoms and experiences, non-pharmacologic interventions, as well as pharmacologic approaches to blood pressure and volume abnormalities, dialysis prescription as it relates to blood pressure and volume, as well as extracellular volume management. As we know, suboptimal volume management may adversely impact quality of life in our patients, and there is always a tension in balancing the volume status within a narrow therapeutic window between hypo and hypervolemia. And both hypo and hypervolemia can increase risk of death in our dialysis patients. Hypovolemia can result in end-organ ischemia with faster decline in residual kidney function, other than causing cramping and fatigue symptoms, vascular thrombosis, and hypotension. On the other hand, hypovolemia can increase hypertension, edema, dyspnea, and fatigue, as well as increasing risk of heart failure. And blood pressure measurement and targets are very important in dialysis patients. However, pre- and post-dialysis blood pressure are imprecise estimates of blood pressure during the interdialytic interval, and they should not be used to diagnose and manage hypertension. Observational studies have shown that pre- and post-dialysis blood pressure have either no association or a U or J-shaped association with all-cause and cardiovascular mortality. And according to these systematic reviews summarizing nearly 20 studies that were done over the years, pre-dialysis systolic blood pressure overestimates ambulatory blood pressure by about 15 millimeters mercury. Ambulatory blood pressure monitoring is therefore considered the gold standard method for blood pressure evaluation. Compared with peridialytic blood pressure, 44-hour interdialytic blood pressure has superior risk prediction for all-cause and cardiovascular mortality. And there is also an association with a graduated increase in mortality risk by quartile of ambulatory blood pressure, as you can see in this diagram. However, the pre- or post-hemodialysis blood pressure show no association with all-cause mortality. Ambulatory blood pressure also identifies white coat hypertension, masked hypertension, and abnormal nocturnal dipping patterns, all of which are associated with adverse outcomes. It is ideally performed as a 44-hour ambulatory blood pressure monitoring for 3 times weekly in-center hemodialysis patients. In home hemo patient, a 24-hour monitoring would be reasonable. And this ambulatory blood pressure monitoring is, however, limited by patient intolerance, availability, and financial constraints. And therefore, home blood pressure measurements is a reasonable alternative. It is taken twice a day, covering the interdialytic days over 1 to 2 weeks. However, peridialytic measurements is still necessary for assessing hemodynamic stability during dialysis. Also, in-office blood pressure that is done not in the dialysis unit has also been shown to be an independent risk factor for all-cause mortality. So how do we define hypertension and blood pressure treatment targets in hemodialysis patients? Currently, the accepted definitions have not been defined. In the absence of high-level dialysis relevant evidence, it is reasonable to extrapolate blood pressure thresholds and targets for interdialytic blood pressure from current hypertension guidelines for the general population. And we can use the 2017 ACC-AHA guidelines for blood pressure targets and thresholds, namely 130 over 80 millimeters mercury, or the 2018 ESH or ESC guidelines that recommend a systolic blood pressure target below 130 for those below 65 years and a systolic blood pressure target range of 130 to 140 for all the others. Clearly, we need an individualized approach for all patients receiving dialysis, taking into consideration the intra- and interdialytic blood pressure patterns, volume management, comorbidities, and frailty. So intradialytic hypotension is important. It has the prevalence estimated to range from 15 to 50% of hemodialysis. It is associated with vascular access thrombosis, inadequate dialysis dose, and mortality. KDIGO suggested the definition as any symptomatic decrease in systolic blood pressure or a Niger intradialytic systolic blood pressure below 90 millimeters mercury, and this should prompt reassessment of blood pressure and volume management. This differs from the previous KDIGO 2005 guidelines, of which they use a decrease in systolic blood pressure more or equal to 20 millimeters mercury, or a mean blood pressure decrease more than 10 millimeters mercury with associated symptoms or need for interventions. Intradialytic hypertension is also important. The estimated prevalence is around 5 to 15% depending on the definition used. And KDIGO suggests the definition as a systolic blood pressure rise more than 10 millimeters mercury from pre to post dialysis in the hypertensive range in at least 4 out of 6 consecutive dialysis treatments. And this should prompt a more extensive evaluation of blood pressure and volume management, including home and or ambulatory blood pressure. And the systolic blood pressure increased more than 10 millimeters mercury from pre to post dialysis accurately identifies persons with persistently elevated interdialytic blood pressure and is associated with increased hospitalization and mortality. In terms of non-pharmacologic interventions for blood pressure and volume abnormalities, salt and fluid restrictions remain the cornerstone non-pharmacological strategies. However, data supporting their effectiveness is very scanty. There are psychological interventions, including behavioral modifications, cognitive therapy, social reinforcement, and stress management. However, they at best indicate only a modest post-intervention decrease in interdialytic weight gain. Some small studies have shown that restricting salt intake can reduce interdialytic weight gain or blood pressure in dialysis patients. However, we do need more studies in this area. Dietary restrictions may impact quality of life, and patients may report feeling blamed for their fluid gains despite their best efforts at adherence, because eating and drinking are integral to social, familial, and cultural interactions. And so dietary restrictions may actually lead to further feelings of isolation by our patients. Empowering patients to adapt to dietary restrictions actually requires a multifaceted approach, and we should promote salt literacy. Motivational interviewing patients with frequent follow-up has been shown to improve adherence, leading to better PP and volume control. Tailor continuous education to patients' health literacy level. Interventions that increase patient activation through education, shared care, and other means of empowerment may reduce symptom burden and may increase patient adherence and will require further evaluation. There are also important pharmacologic approaches. When should antihypertensive medication be used? Now, the decision requires the consideration of 2 indications. One is blood pressure lowering alone, or secondly, targeting cardiovascular protection. So for blood pressure lowering, we can consider the non-pharmacologic strategies that we've just discussed. If blood pressure is still not at goal, then we can add or titration the blood pressure medications. If blood pressure medications are interfering with volume management, it is reasonable to consider reducing blood pressure medications to allow more volume removal. For cardioprotection, it is reasonable to initiate these medications for CV indications. One would not reduce ultrafiltration to allow increasing blood pressure medications. So optimizing volume stasis always takes priority. Examining these mineralocorticoid receptor antagonists. There is preliminary data to also show that amlodipine reduced cardiovascular events compared to placebo in hemodialysis subjects with hypertension. On the other hand, the ACE inhibitor or ARB, I think the data are more inconclusive in terms of cardiovascular protection. It is important to consider the dialyzability of hypertensive drugs, and clearly within a class, the dialyzability may differ. For instance, lisinopril is very minimally dialyzed, whereas lisinopril, over 50% are dialyzed. For beta blockers, atenolol and metoprolol are also highly dialyzed, in contrast to carvedilol and labetalol, which are very minimally dialyzed. So this is actually an important consideration in our hemo patients. Although there is currently no randomized controlled trials examining the dialyzability and outcomes, it is actually reasonable to consider the intradialytic blood pressure patterns with regard to dialyzability of these medications. So in subjects with intradialytic hypertension, one should consider using dialyzable medications. And in subjects with intradialytic hypertension, perhaps one should prefer to use non-dialyzable drugs like carvedilol. What is the optimal timing of blood pressure medications administration? KDIGO guidelines in 2005 have suggested that hypertensive medications should be given preferentially at night because it may reduce the nocturnal surge in blood pressure and minimize intradialytic hypotension that may occur when drugs are taken in the morning before dialysis session. And also they suggest to discontinue antihypertensive medications prior to the dialysis session to prevent intradialytic hypotension. However, there are so far no data to suggest that taking blood pressure medications at night for dialysis patients, although there are some preliminary data in the general population. So it is most important that the patient do remember to take the medication. In terms of withholding blood pressure medications prior to dialysis, this is also a highly variable practice, and so far there is no convincing data to show any difference in terms of the hypotension risk among those subjects who withheld or took blood pressure medications before the dialysis sessions. There are, however, theoretical harm in prolonging the interdialytic hypertension and arrhythmic risk if these medications are withheld prior to dialysis. And with intradialytic hypotension, one should consider withholding short-acting drugs immediately pre-dialysis. And we should not routinely withhold blood pressure medications. And we also, in fact, withholding the drugs with long half-life is likely not useful. There are medications to consider that can increase the blood pressure in intradialytic hypotension. However, we should prioritize non-medication strategies. For instance, reassess dry weight, cool dialysate, modifying dietary sodium, and evaluate cardiovascular status. There are medications that can be considered, and one of the most widely used and best studied is Midodrine, which is an oral vasoconstrictor. However, the data are still weak. Nevertheless, it is reasonable to consider its use in patients with persistent hypotension when other interventions have already been adopted. So this is a systematic review summarizing the 10 trials looking at Midodrine. There is improvement in symptoms in 6 out of the 10 studies. However, hard clinical endpoints are not examined. Also, availability is limited outside United States. It relates to blood pressure and volume. For target weight, this is a critical element in dialysis prescription because if it is too low, it can lead to hypotension. Too high can result in volume overload. So there is a very narrow therapeutic window in order to avoid acute and chronic complications of volume depletion and volume overload. Now, target weight differs in concept and in practice from the estimated dry weight, as target weight can vary from treatment to treatment and can change if patients gain or lose weight. The other modifying strategy or parameter is ultrafiltration rates. Higher ultrafiltration rates, as low as 6 mL per hour per kilogram, are associated with higher mortality risk. There is strong biologic plausibility data that support a relationship between higher ultrafiltration rates and end organ ischemia. A critical unanswered question is how to balance the potential risks from higher ultrafiltration rates with the potential risks from volume overload. The hemodialysate composition is the other key parameter in hemodialysis prescription that can influence blood pressure and volume status. So higher dialysate sodium increases intradialytic weight gain and blood pressure, but at the same time it also reduces hypotension and symptoms. On the other hand, lower dialysate sodium is associated with lower intradialytic weight gain and blood pressure, but also associated with intradialytic hypotension and symptoms, including cramps. And so therefore, the dialysate sodium prescription has to be individualized based on your patient characteristics. High dialysate calcium is associated also with greater hemodynamic stability. However, it may result in more positive calcium balance and thus greater risk of developing vascular calcification and also losing vascular elasticity. And that may result in maladaptive vascular and heart remodeling. However, we do need more longer-term studies to assess the relationship between the use of high dialysate calcium in terms of the long-term blood pressure and volume status. The other parameter is the magnesium. Higher dialysate magnesium may reduce intradialytic hypotension and arrhythmic risk. However, we do need more longer-term studies for further evaluation. The other dialysate composition, including potassium, glucose, and bicarbonate, has not been associated with any significant blood pressure effects. So here is to present to you a recent published randomized controlled trial comparing low sodium versus conventional sodium dialysate in hemodialysis patients. So over a 12-month follow-up period, relative to the 140 millimolar dialysate sodium, a dialysate sodium of 135 millimolar didn't change left ventricular mass index, but there were significant reductions in intradialytic weight gain, extracellular fluid volume, and plasma BNP levels at 6 and 12 months for the lower dialysate sodium. Also, the lower dialysate sodium is associated with an increased intradialytic hypotension, both at 6 months and at 12 months. So clearly, we do need to individualize the sodium prescription according to the patient characteristics. There are other non-pharmacologic interventions to prevent intradialytic hypotension. So one can actually increase the dialysis time by lengthening the dialysis treatments or increasing the frequency of dialysis treatments or utilizing home dialysis modalities. However, this may be a challenge in resource-poor regions and also depending on patient preference. The other intervention is to decrease the weight gain by more stringent dietary control in terms of the salt and fluid restriction and also avoid sodium loading during dialysis. And one can also increase non-dialytic sodium and fluid loss by using diuretics. So therefore, to summarize, in order to target the blood pressure and volume abnormalities, we do need to take into consideration the patient factors and then adopt an individualized approach targeting at the specific patient factors. For instance, if you have poor ultrafiltration tolerance, for these patients, one can consider increasing the dialysis time by the frequency or duration, or changing some of the dialysis prescription, for instance, using cool dialysate, avoiding sodium load, and also avoiding very low calcium. For patients who have very higher interdialytic weight gain, one can consider reducing the dietary sodium and fluid intake, and also reducing the dialysate sodium prescription, and also increasing volume removal using other means, for example, by diuretics, or through the skin or GI tract and respiratory tract. For subjects who have incorrect target weight gain resulting in volume overload, one can actually improve the assessment of volume status by clinical exam or by using, for instance, bioimpedance, which is a technology of which you can actually assess the dry weight and also estimate the degree of overhydration. However, we do need more studies for the bioimpedance. Now, residual kidney function is a very important parameter in dialysis patients, as we all know. However, at the moment, there is very limited consensus as to how frequent we should be assessing residual kidney function. There are also uncertainty about the ways that we should assess residual kidney function. So conventionally, we are using 24-hour urine collection with a simultaneous one-off blood sampling to estimate the urea and creatinine clearance. And then residual kidney function is defined as the mean of urea and creatinine clearance. However, for hemodialysis patients, there is some suggestions that using the entire interdialytic period urine collection may be preferred. And so we do need more studies to clarify this. In terms of strategies to preserve residual kidney function, there are some small and data studies to suggest high flux may be more beneficial than low flux. And also there is randomized controlled trial to show that frequent nocturnal dialysis may increase rate of loss of residual kidney function. The RAS blockade has been better studied in PD patients, and there are several small trials, and however, there are no data as yet in hemodialysis patients. And the other strategies would include avoid intradialytic hypotension as well as avoid the use of nephrotoxins. So in summary, this is the slide providing a conceptual framework to individualize dialysis prescription. In order to achieve the various goals of end-stage kidney disease care, whether it is to improve or maintain quality of life and other patient-prioritized outcomes, reduce or prevent symptoms, reduce cardiovascular complications, and improve survival or maintain function and or independence, we need to modify the various dialysis prescriptions as we have presented earlier, and also adopt non-pharmacologic modifications in our patients, taking into consideration individual patient characteristics and also their dialysis-related consequences, such as intradialytic hypotension or hypertension, interdialytic weight gain, as well as their volume status and residual kidney function decline. In terms of extracellular volume management and technology-based considerations, there are different tools available to assess extracellular volume status. However, there is currently no gold standard method in assessing extracellular volume, and we should still be using clinical exams to assess volume status in our patients. So some of these strategies, for instance, temperature biofeedback, cool dialysate has been associated with hemodynamic stability, and currently there is an ongoing trial to evaluate their effects on cardiovascular events. For blood volume monitoring, there is conflicting data whether relative blood volume monitoring can predict intradialytic hypotension. However, there are some clinical trials preliminary showing the relative blood volume guided dry weight reduction may improve blood pressure control in some of the hypertensive hemodialysis patients. So although ultrafiltration profiling, isolated ultrafiltration is being used in clinical practice, there are very limited supporting evidence of their effectiveness. For sodium profiling, there is top data suggesting that the routine use of sodium profiling to limit or prevent intradialytic hypertension was associated with increased all-cause mortality. Sodium profiling must be used judiciously since it may result in sodium loading and subsequent hypovolemia. In terms of bioimpedance, there are actually emerging data evaluating bioimpedance. However, there is currently not enough evidence to justify their routine use for intradialytic volume management. There may be a role for bioimpedance in extracellular volume management, but it would require further investigation. In the last part, volume-related patient symptoms and experiences. Incorporating patient symptoms into dialysis prescription considerations may help to focus discussions on the aspects of care that are most important to patients and help align the goals of care for the patients and for healthcare providers. Patients prioritize symptoms that are possibly related to volume, such as fatigue and cramping, for treatment and new research, as shown in the SONG initiative. And patients should be engaged, educated, and encouraged to report symptoms routinely. Ideally, a symptom measurement tool would capture relevant symptoms and their severity in real time without being burdensome to patients. And we do need more study to identify this symptom measurement tool in our dialysis patients. In conclusions, managing blood pressure and volume in hemodialysis requires an individualized approach with integration of numerous clinical dialysis treatment and patient factors. Emerging technologies and clinical protocols offer promise for near-term advances in blood pressure and volume management. There is a clear need for the design and implementation of future randomized controlled trials in this critical yet understudied area. This slide summarizes the key research recommendations prioritized by the work group in the different aspects of blood pressure and volume management. For your information, the full report of this Controversies Conference was already published in Kidney International earlier this year, and you may refer to the full publication for more details. Before I end my talk, I would like to once again thank KSN for inviting me to deliver this talk on behalf of the group, and I would also like to thank KDIGO for inviting me to join the steering committee, and it has been a great pleasure and honor to work in this group. Thank you very much for your kind attention.